வர மாட்டேங்குது.
Good afternoon, sir. Welcome, sir.
Good afternoon, sir. Sorry, very sorry for the delay.
No problem, sir. We last time we started by 2:05 only.
2:05. Like miscalculation. Can we start, sir?
Sir, I think we should start, sir. Good afternoon, everybody. On behalf of SRM family, I welcome you all for the last of the 9 lectures. And that is going to be a beautiful lecture today. You please all mute by yourself so that there will not be a disturbance for recording also. Thank you, sir. You can start, sir. You can start sharing the screen.
Thank you very much, sir, for the very kind words and a great opportunity. And let me. Oh wait, sir, can you please allow me to share screen, because at the moment I am not able to.
Yeah, you still share, sir. Wait, sir.
It's written. You cannot share screen while other participants is sharing. So I don't know why that is coming.
Someone else is trying to.
Yeah.
Now you share, sir. Now you share.
Now it is okay, sir. Optimize for video clip. Sorry, just a minute. Now it is coming. Just a minute, sir.
Someone else was sharing.
Oh, okay, sir. Okay, sir. I will, but there's a problem. Just a minute. Just a minute, sir.
Okay, sir. Take over.
Sometimes, yeah, it will now come. I will. Yes.
Yes, just go.
Coming, sir.
Yes.
Yeah. Thank you very much. A very warm good afternoon to all of you, and thank you, Professor Arunan sir, for the very kind.
Right, sir.
It's a great privilege to be here, and discussing about various aspects of EEG, and today being the final session, this is a topic which I think in the next decade, it's going to be a very important, all neurologists should have a good idea about the video telemetry monitoring because it's very useful for various aspects. So I'm going to talk about the utility of video EEG monitoring in the current setup. And I hope through this, I will incite some interest and generate some debate on how to utilize this particular tool. I think all of us should be familiar with this. So basically, I'm not going to go into this. Now, I'll start off actually with the potential disadvantages, and that's one of the reasons why the video EEG is not very commonly used. One of the important things is that the patients need to be hospitalized. So obviously, it's going to be more expensive. So that's one of the problems. So we must always, whenever you have a test, you must know actually more than the indications, you must also know the limitations of any particular investigation. So hospitalization is one thing. Another very important point is that there's a need for specialized personnel and resources. So there's a lot of expertise needed to actually interpret these things. It's very, very important. So we need to be trained properly, not only the neurologists, but also the technologists and the other personnel, the nursing. And because of this, it can be quite expensive. The other important point is that, during the EEG, normally when you do a routine EEG, as we have already shown so many times now, the routine EEG is usually done in the interictal period. And we do it with the patient's full cooperation, in the sense that the patient is made to lie down very quietly with eyes closed, relaxed. But in video EEG, it's not like that. The patient is otherwise quite normal, in the sense that they are not asked to, lie down in one place just with eyes closed all the time. No, that's not the way it is. The patient is able to do whatever he or she is doing. Say, for example, the patient may be actually working, talking, working on the computer, reading a book, whatever it is, watching television. So that means, the EEG will be full of artifacts, both interictal. The ictal EEG itself is quite challenging to read. So may have a lot of artifacts. EEG changes may be very subtle. Changes in the scalp, even though the seizure is there, the scalp changes may be a little late. And in very importantly, focal seizures with preserved awareness. In earlier times, it used to be called simple partial seizures. Now the present classification, you don't call it simple partial, you call it focal seizures with preserved awareness. They may not have any changes at all. And during the recording, you may want a habitual spell to be recorded. But then when during that period of time, you say you may have asked the patient to come for a 24-hour recording or a 48-hour recording. Unfortunately, during that period, you may not actually have a clinical spell during that time. So that's another disadvantage. And if you don't record the spell, then just the interictal EEG alone may not be enough to prove a reliable indicator. So if you understand these limitations, then you will understand the indications better. So that's why I put the slide initially itself. So you must have a good idea about the potential disadvantages and then how to effectively utilize. Whenever we want to effectively utilize something, you must know the limitations of that particular. Now, let us see what are the applications of monitoring. Now, very, very important. This is the very, very most important utilization, differential diagnosis of episodic phenomena. Now, when you start off, you do not know whether that episodic phenomenon, which is a paroxysmal event, which is lasting for a short duration, it could be epileptic, it could be non-epileptic. In the non-epileptic, it could be either psychogenic non-epileptic or physiological non-epileptic. There's so many different conditions that can produce episodic phenomena. So that's a very important point. So it's very useful for the differential diagnosis of that. Now, supposing somebody has actually got, you know that, okay, this episodic phenomenon is clearly epileptic. and it's a seizure. Now you would like to document that type, and you would like to, it's very useful for classification. So that's another very important utilization. And obviously, in our setup, we use this quite a lot, which is for the pre-surgical assessment. And sometimes, what the patient describes may be only a tip of the iceberg. So for example, the patient may say, I've had, 1 or 2 blank spells. Or the patient's attender may say, sometimes he appears a little blank. That may be an absence or whatever it is. So, but what the patient has observed or what the attendant has observed may be just 1/10 of what actually the patient is happening. So you have to determine the frequency. You just do a 24-hour recording. You would know that, okay, what the patient has actually described may have been only 3 or 4, but you might have recorded at least 20, 30 without the patient's knowledge. Detection of subtle seizures, very, very useful. And for each of these, I'm going to show you examples. Study of seizure precipitants, reflex epilepsies. I'm going to again show you a lot of examples of that. So all these are important. So now we'll start off with the first. So these are all the indications: differential diagnosis, documentation and classification of known seizures, pre-surgical assessment, determining frequency of known seizures, detection of subtle seizures, and study of seizure precipitants. Now, let us now start off straight away with, now let us look at the first category: documentation, classification of known seizures. So that means, the person already has got epilepsy, seizures, but you do not know whether, is it a focal seizure or is it a generalized seizure, because it's very, very important. It determines the choice of medication. And in one of the studies, I mean, this is long back, but it is as true now as it was in 1981. And after a post-video telemetry, it has led to the revision in about nearly half the patients. So you can imagine the impact that you can actually have with proper classification. You can actually result in change of medication. And it also helps in counseling patients. So this is a very important point. I'm going to start off now. All this particular lecture is going to be on a lot of actual cases. All this has been done in our setup at different places, but in our setup. So where I was involved predominantly. So all this is very practical. So now let us see this case. 26-year-old, full-term normal delivery, but very mild developmental delay, both motor and cognition, cause not known. Very mild, maybe is very mild static encephalopathy, nothing more than that. And studied up to class 12, no febrile seizure, no trauma. And she started having unprovoked seizures from the age of 19. The seizures were that she would not have any aura, and she would have generalized tonic-clonic seizures, but infrequent, once in 6 months. One cluster of seizure in September 2007. And then the anti-seizure medicines tried were valproate. I'm talking of this case was, this is one of my patients which we did in 2007. So November 2007. So that's pretty long back, but it's just illustrative case, very nice. Anti-seizure medicines, valproate, 2004, carbamazepine, recently clobazam, phenytoin, because of the seizures have been increasing, and she's been insufficiently controlled with many of the medications. No deficits. EEG, many EEGs were done. They were all considered to be normal. One EEG once showed some bifrontal sharp waves. So interictal EEGs were not very, clear. The history suggests, whether it's a focal seizure with generalization or is it an idiopathic generalized epilepsy. But then if it is idiopathic, then she's got some mild developmental delay. So is it a symptomatic generalized epilepsy? So we don't know what exactly is actually happening. So the MRI was essentially normal, but may have been showing some very mild frontal atrophy on the right side. but nothing much. It's not a very big lesional epilepsy. So let us see when we recorded the seizure. So the seizure, why we did the video EEG, that's a very important. So every time you do a test, you need to know what is the indication for this test. So this test is basically done for two things. Is it a primarily generalized epilepsy, or is it a focal epilepsy becoming secondarily generalized? So that's what it is. So what we did was we put her in for a 72-hour monitoring, and we slowly tapered the medication, reduced by 30% on day one. Generally, that's the practice that we follow. The anti-seizure medicine is usually reduced on day one by 30%, day two, 50%. And day three, generally we are off the medicine. So that's how we normally do. And she was on carbamazepine and phenytoin, and that was reduced. And I'm going to show you. Oh, so that is not playing, I think. I'm sorry, it's not playing. Now, what we found was, I'm sorry that particular video did not play, but I will later on, all those videos will start playing. I'm sorry about it. Now, what it showed was that this was a generalized tonic-clonic seizure. And she had, I must describe, unfortunately, this is not playing, but what she had was myoclonic jerks followed by tonic and then generalized tonic-clonic. So she had myoclonic, tonic, tonic-clonic, bilateral, symmetrical, simultaneous. So this was an IgE syndrome. And once you did that, then she became normal. So that's it. So what we did was we classified that, yeah, that this is an IgE syndrome, an idiopathic generalized epilepsy syndrome. And what we did was, at that time, because she's a woman, valproate would have been the first choice. We did not give that. We gave her a combination of levetiracetam and lamotrigine, and she responded extremely well to that. And now she was on the two wrong medicines. For that particular condition, carbamazepine was not appropriate. Phenytoin also was not appropriate. And that's the reason why she was not responding well to the medication. She was having the medication. And valproate, which was given some time ago, she had some weight gain, and therefore that's the reason why they had changed over to another medicine. But the problem was when they rightly changed it, but the problem was the medication was not the best medication for her seizure type. And that's the importance of doing a video telemetry, to record the seizure, get the classification correct. So that's the first point. So this is another patient. You just have a look. Is a known epilepsy, but we do not know what it is. You just see this. Now, this is a 23-year-old woman, seizures from the age of 13. Now she gets jerking on the face for a few seconds to a minute, or sometimes more than a minute. And she gets it once every few weeks, facial jerking. Now this facial jerking is followed by falling down and generalized tonic-clonic seizures. And she's on oxcarbazepine. Now, why oxcarbazepine? Because it looks like a focal seizure with bilateral tonic-clonic. The reason is that it starts with jerking of the face. So when it starts with, that means it's starting focally and it's becoming bilateral tonic-clonic. And for a focal seizure with bilateral tonic-clonic, carbamazepine or oxcarbazepine or phenytoin are very good choices, very good choices. There's no doubt about it. But unfortunately, this woman is not getting controlled with an appropriately chosen medication. Now, this patient comes to the OPD, and in an OPD, when you have a history like this, there is no doubt that you would choose a drug like oxcarbazepine. It's not a problem at all. But here she's not responded to that. Now, this was in 2010. Now, because she was not responding, we just wanted to put her in and then do a recording just to see, one is for classification and if possible to record an attack. Now you just observe her face. I'll show you now. Oh God, it's again not playing. I don't know why. Oh. Sorry about it. Just a minute, if you don't mind, I will. Are you able to? Are you able to see now? Are you able to see?
Yes, sir. Yes, sir. Yes, sir.
Just watch her face. Okay. What could be made out? Again, see that. Mouth. There is some jerkiness of the mouth. Perioral jerkiness. Again, I'll play. You can see that there is some jerkiness of the face. There's also some minor jerkiness of the limbs. But this is what she gets. Her face, yeah, that's it. You can see that the chin is jerking, the mouth jerking, a little bit of hand and jerk. So what is this? Now this is what we recorded, and this is what she says she gets before she actually falls down. And that is it. Now this is what she has. You see this is a burst during the time of this jerking. You could see that there is a burst of generalized spike, multiple spike and wave discharge. And this is classical of a condition called perioral myoclonia with or without abscences. So that's what the patient has. She becomes a little blind. She can actually fall down. And this is actually a kind of a idiopathic generalized epilepsy syndrome. And so that is, so here with this EEG, which shows a generalized spike, polyspike and wave discharge. And during that time, all she has is only perioral jerking. It's very clear that this is not a focal epilepsy with generalization. This is an idiopathic generalized epilepsy syndrome. And oxcarbazepine obviously is not the choice. You can choose another drug which is broad spectrum. And in her, what we did was we changed it over to levetiracetam, but that did not respond. We changed over to zonisamide, and with zonisamide, she is completely single attack. And so that is something that we have to. So the video EEG actually helped in the classification of the seizure. So that's what it is. Now let us look at another example. And you can see here that this is a 14-year-old girl, recurrent episodes of jerking of the right hand since the age of 11. Recurrent episodes of jerking of the right hand since the age of 11, is aware of it on many occasions. That means she knows that her hand is jerking. Now, sometimes this hand jerking has resulted in, as progress to falling down with loss of awareness and consciousness. Now, attacks usually increase during periods of stress, such as exams. And she has been on multiple anti-seizure medicines. She's tried various medicines, but she's not been controlled with carbamazepine, phenytoin. Now, the reason why carbamazepine and phenytoin were used was because, you know, this particular history, again, it's a focal seizure. You can see that there's jerking of the right hand. And she's aware. So it's actually basically, are they focal seizures with preserved awareness, or focal seizure with impaired awareness, or because, you know, these attacks are happening during periods of stress, are they non-epileptic? Because she says she's aware of it. So all these are pointers, and she's not responding to medication. These are the questions. So you would like to know what is happening. So let us see what we did. Now, you look at this girl. Now we have connected her to the video telemetry. Now this was way back in 2015.
அதே மாதிரி சின்ன பொண்ணு பெரிய பொண்ணு அப்படிங்கிறவங்களுக்கு அவர்களுடைய ஏற்ற இறக்கம் இந்த எல்லா காரணங்களையும் வந்து அவ அந்த ஒரு 20 seconds maximum 90 seconds. இந்த வருது பாருங்க எங்க இதுதான் சார் சொன்னீங்களா ஜாஸ்தி ஆகுதா
So you can see that what actually happened was, I'll again play that.
அதே மாதிரி சின்ன பொண்ணு பெரிய பொண்ணு அப்படிங்கிற அவருக்கு ஒரு ஏத்த இறக்கம் அதுலயும் கொஞ்சம்
Father is describing what she actually gets.
இந்த எல்லா காரணங்களையும் அவ அந்த ஒரு 20 seconds maximum.
Father is describing her attack, how it happens. He says that she gets it, and every morning some 20 seconds she'll get. It's the attack.
அதே மாதிரி சின்ன பொண்ணு பெரிய இந்த எல்லா காரணங்களையும் 30 seconds maximum 90 seconds. இந்த வருது பாருங்க
So that's what it is. But so we thought it is actually a non-epileptic event, because you saw that and the kind of movement that she was doing was also it's not very typical of an epileptic seizure. But to our surprise and consternation, we found that you can see that the background is going on very well, and all of a sudden, coinciding with the jerking, you can see these generalized spike, polyspike and wave discharge. Generalized, it's not focal. That's the beauty of it. She is fully aware of what is happening. She's actually even interacting. But during that jerking of the hand, which looked almost non-epileptic, there's a very nice generalized spike, polyspike and wave discharge, which then when the jerk ended, it ended like this, and the background again becomes normal. And without this video telemetry, we would have just gone on as non-epileptic event. So that is very, very striking. So this actually turned out to be an idiopathic generalized epilepsy with focal features, and that can sometimes happen. So IG syndrome with focal features is a well-known entity. And so we have to, if somebody with a focal seizure is not responding to the classical medication like carbamazepine or phenytoin, it's better to look for whether it's an IG syndrome with focal features as one of the differential diagnoses, apart from having non-epileptic as one of the differential diagnoses. So this is a very good example of that. Now let us go to the next category, where you already know that the patient has got seizures, and but you do not know what is the frequency, and in other words, subtle or hard to recognize seizure. For example, somebody may be having absences. It usually is underreported by about 10-fold. That means for every one seizure that is recorded or reported, there may be 10 times more number that the patient may actually have. And this is extremely useful for anti-seizure medication adjustment. And this is very useful. We sometimes do this, and it may be helpful to choose the right anti-seizure medicine. And the other thing is that if somebody has known absences, and you would like to know whether the patient has completely become all right, so you can actually do it overnight or whatever it is, and then and before a candidate for driving license who's had spike wave discharges earlier, you just would like to know whether this patient is actually becoming completely seizure free or not, or having subtle seizures. This is to do a 24-hour video telemetry. So that's what it is. So detection of subtle seizures, you see this, are these, for example, now any of these episodic phenomenon, there are lots of episodic phenomena which are epileptic, and there are lots of episodic phenomena which are non-epileptic. For example, tics, odd movements, lapses of concentration, And then you have subclinical EEG events. Are they ictal clinical phenomenon apparent on careful observation? So you wouldn't know that they are actually seizures or not. And there is a condition called transient cognitive impairment, which just at that moment, for a few seconds, the patient may actually hesitate on testing. And then you know that, oh, that patient has become absent. Now, I'll just show you some examples. Now, this is a 4-year-old boy who started having seizures from the age of 2. This is very clear, the vomiting and eyes to the left, which means that it is coming from the right occipital cortex, and head and face to the left with generalized tonic-clonic seizure. Another seizure type is myoclonic jerk. And the other seizure type is drop attacks with arm abduction. So multiple seizure types, daily multiple attacks, multiple medications, hyperactive. This is the story of this child. With this history, you think that this patient has got a Lennox-Gastaut syndrome or a symptomatic generalized epilepsy syndrome, because there is no doubt that he's got multiple types of seizures and so on and so forth. Again, 1 minute, I think this may not play. So what I'm going to do is, I don't know why it's not playing, but what I'll do is, if you bear with me for a minute, I will play it for you. Okay, 1 minute, sorry.
You can play like this itself, sir, without making it
Yeah, I can do that.
light show.
Can you see that? This boy is watching television, and you think he's actually concentrating on the television. And now he's better. You see that? Very, very nice video. He is now normal. But if you watch him initially, before that, he is now talking very well. But you look at him now, he looks quite normal. He looks as if he is actually intently concentrating, looking at television. But you realize now only that actually during that period of time, he was subtly acting. This is not a dense loss of awareness. This is a subtle loss of awareness. And this is classical of an atypical absence. And this is the EEG during that time. You see that this boy is actually staring. And you see that the EEG is, very high amplitude, irregular, spike and slow waves, high amplitude, diffuse. These are not classical 3 per second spike and wave discharge that you see in a typical absence, but this is classical of an atypical absence. And you see when he suddenly the EEG becomes normal or relatively normal, not normal, but relatively normal. You see suddenly, I'll go back to the previous page. This is during that atypical absence when he's staring. And at the end of it, suddenly, the EEG becomes normal. And this is classical of an atypical absence. So that is, so this subtle, now he would have about 100 to 200 per day. Now the parents would say, yeah, he's kind of, maybe 1 or 2, he may just be a little absent, but otherwise, so unless you do this, we could document about 150 of these. And this was done about many, many years back. This was, I think, in 2009. And you see his interictal awake record. Background is slow. And then you see these generalized spike, polyspike and wave discharges. And in sleep, you see this, what is called a GPFA, or generalized paroxysmal fast activity. GPFA, generalized paroxysmal fast activity. And this means slow background, slow spike and wave, fast spike and wave, GPFA, all these things combined together. What we did was, so this is classical of an epileptic encephalopathy. One of the types is this Lennox-Gastaut syndrome. You see that we gave him steroid, and we chose lacosamide and zonisamide, IV methylprednisolone. He's recovered almost fully now. So that's, and the last 10 years, he's been all right. So that's the beauty of it. You see, 6 months after treatment, you see his EEG has almost become normal. And you see that only occasional one generalized spike, but otherwise nothing more than that. You see that, so the encephalopathy has been cured, and he does have some interictal discharges, but not the epileptic encephalopathy. This is a classical epileptic encephalopathy where the EEG itself is contributing to the cognitive decline. And one of the important components of the cognitive decline is the atypical absence. And you have to record these atypical absences to understand the magnitude of it. See, very nice. This EEG is fairly normal 6 months after treatment. You see his background is, this is a sleep record, and you can see some subtle sleep spindles also coming in, which means that this physiological sleep activity also is slowly coming back. So that's a very important point. Now, sometimes we produce an epileptic encephalopathy. We means I'm talking about as neurologists, as treating physicians. We don't do it just, just like that, but we do it with good intention. But sometimes in a particular child, it may backfire. And this is what happens in a benign childhood localization related epilepsy, or the classical one is a benign Rolandic epilepsy. Oxcarbazepine can induce worsening sometimes, and what is called an atypical, it can produce what is called an atypical BRE syndrome. And this child, who was otherwise normal cognitively and was having occasional seizures in sleep during sleep, would and found to have benign Rolandic epilepsy, was given oxcarbazepine, which is the right medication, no problem. But in a small percentage of children, if oxcarbazepine is given for benign Rolandic epilepsy, they go into what is called an epileptic encephalopathy. And I just loaded all these just yesterday fully, and for some reason it is not, I don't know why, it's very unfortunate, but okay, now that is very sorry, very sorry. I don't know. No, that's not the one. Sorry, sir. I don't know why it's not playing actually. Yeah, okay. That's called atonic seizures. Classical atonic seizures that the child has been getting very frequently ever since treatment had begun. Till that time, the child was quite normal. Again, just watch what happens. There's a loss of tone, and the child actually so that is what happens. And so this was her, she was clearly encephalopathic, but you can see here that on this on the left hand side, this was her handwriting during that encephalopathy period, during the time when she was, and this is the handwriting after we cleared her encephalopathy. You see, it has significantly improved. This is after just an overnight video EEG recording, which recorded these these kind of atonic spells that was there, and so that's what happens. Now she's become normal. The same child, once oxcarbazepine was removed and changed over to valproic acid, she is
இப்போ நல்லா ஆயிடுச்சுங்களா? இப்போ நேரா பாருப்பா, நாக்க
so,
வெளியிட்டு. குட். பல்ல
so
காமி.
she's become normal. So the point here is two things are there are some very important points. Now in benign Rolandic epilepsy, usually the drug of choice is oxcarbazepine or valproate, but in a small proportion of children, oxcarbazepine can induce epileptic encephalopathy, and they go into what is called atonic seizures, like what I just now showed. And you'll have to document that, remove the oxcarbazepine and put them on, say, a drug like valproate. You have to avoid sodium channel drugs in atypical BRE cases. So that's a very important point, and they become completely normal. So that's a very, very striking point. Now, reflex epilepsy, study of seizure precipitants is a very important, another video EEG is extremely useful for study of seizure precipitants. In reflex epilepsies, various types of of stimuli, for example, auditory stimuli, visual stimuli, cognitive stimuli. So many stimuli can actually produce a seizure. So this is the best way to document those kind of things. And then, of course, you can study various situational factors. Now, the time of the day, task, alertness, relaxation, awakening, all those kind of things can be studied during the video EEG recordings. And then in self-induction. So those are the things. Now, you can see here that, yes, I'm going to show you now. You just see this. So this is a classically sound-induced startle seizure. So we made an unexpected sound, and then the child had a very sudden, abrupt, bilateral, it was a kind of a myoclonic jerk. It is diffuse. And you see, that's what it is. That's during the EEG. See, that's where the sound came. And you can see that the background has suddenly got flattened out. And you can see some low voltage fast activity indicating that this is a tonic seizure rather than a myoclonic seizure. So although the brief tonic component, and that's why you see that muscle activity there, then it again becomes like back to its original self. So that is a very striking feature that you can see. Now you can see that there is another type that the child gets. Same child getting another seizure type. You see they don't recognize this as a seizure. You see this? Child is actually just one or two brief words. That is looking another sound, but nothing has happened. So, with the unexpected sound, she did not have the attack. Relatively silent period where the child was relatively silent and there was some mild chewing kind of a movement. That is a seizure, but it doesn't look like a seizure. It's only when the child started crying that the child came out of the seizure. So you can imagine that it's very difficult for the parents to know which is a seizure, which is not a seizure. So this child had auditory induced, stimulus induced startle seizure. The child also had focal seizure with impaired awareness. You can see that the EEG during this time, this is again an atypical absence. You can see here ictal, and during that time the child is having subtle chewing abnormalities. So this is a classical complex atypical absence. And when the chewing stops, the child becomes better. And this is the time when the child is actually crying. The ictus ends and the crying begins. So this is again, so unless you do the video telemetry, you will not know. Then you can now counsel the parents, okay, when the child becomes silent, they're actually seizures. So now to understand the effectiveness of medication, now let us see how many times the child becomes silent, has that count come down, has the count increased, all those points. So we must have a documentation, and that's the reason why a video telemetry is very useful to understand that point. Now, this is another child. To clean up this child, because every time water is poured on the face, her face is water. Micronic jerk and falls down. So that is another type of stimulus-induced seizure. So that is so that's another, and this is what happens during that time. You see that water is splashed, and at that time the child actually falls down. So another type of reflex seizure is a common one, relatively common in our part of the country. We see this quite often, and I want to see now she's actually now let's see. Like a statue. Notice that, yeah, she's been silent. Classical reflex eating epilepsy. And video EEG has very nicely shown that this is really a hypomotor seizure. And the next one is a very the same patient, but you see what happens to this patient during the second meal. You see that she's eating, she's become silent. Like a statue now. And not responding at all. Very nice testing. Now you see what happens as the head is slowly now turning to the left forced manner. There is a asymmetric tonic. Asymmetric tonic with a figure of 4. And that is a figure of 4. I'll show you the figure of 4 at this point. Yeah, that's called a classical figure of 4. The head has gone to the left. The left arm is extended, the right arm is flexed, and therefore this is called a figure of 4, classical asymmetric tonic seizure. And that means the seizure is arising from the right hemisphere. That is why it's pushing to the head to the left. The right arm is tonic, the left arm is flexed. And the focal seizure with impaired awareness going on to bilateral tonic-clonic. And so that's again precipitated by eating. So this is a reflex eating epilepsy of right hemisphere origin. And this is during the seizure. You can see that just as the that's the eating artifact, chewing artifact is going on. And then she stops chewing at this point. And then you see the ictal transformation taking place very, very nicely. And it is seen predominantly over the right hemisphere. Very, very nice, good description of that. Now, sometimes you get what is called this is a very rare video that we have shown. And this is a video, you can see that the child gets, every time gets, this is a micturition induced seizure. Yeah, that's a child who's having every time the child micturates, the child will fall down. And we'll have a bilateral abduction of, this is a classical SMA type of seizure. And you can see that very nice rhythm that you get in the midline central region, and very classical reflex seizure that you get. So again, I'll show you, see that child is passing urine, and there's bilateral arm abduction, there's a flexion of the trunk, and then the child falls. There is a very nice, there's a midline rhythm that is going on. And post-ictally, as the child is recovering, you will see these focal spikes, which are seen predominantly over CZ, the midline central, very nice. And on the right side, right frontocentral, very nice seizure. This is called micturition-induced seizure. And this is another kind of a reflex epilepsy. So you have seen reflex epilepsy, auditory to water, touching the face. The third one we saw was on eating, and the fourth one, micturition. So these are, then there's another category. Are these epileptic seizures? So that is another very important this thing. You see that this is a child, a 10-year-old, only child to non-consanguineous parentage. Birth is normal, motor milestone slightly delayed, clearly delayed, walked only at 2.5 years. Speech, she still lisps, no febrile seizures, no trauma, no meningoencephalitis. But in the last 4 years, that means from the age of 6, within 30 minutes of falling asleep, suddenly she has a suffocating feeling. She has gurgling sounds, struggle for breath, arching of the trunk, no limb posturing, no jerks. So this is what she gets. She gets a suffocating feeling, gurgling sound, struggle for breath, arching of the trunk, multiple times every night, 10 to 15 every night. Nothing in the daytime, nothing, not in the daytime, nothing in wakefulness. If she sleeps in the night, in the day, she may get one, but not when she is awake. So this is what it is. So what are these attacks? Let me now show you this. Let's see what we have done. I will show you what we have done before I explain. You see, we have now put a cannula in the nose to detect the airflow. We have done the chin EMG. And so we have done what is called a polysomnography plus an EEG. So that's a simultaneous PSG plus EEG. And just have a look at what is happening now. Utilisation, there's a struggle. Suffocation, sounds, gurgling sounds, cooking sensation, hacking the mouth. It lasted only at this salivation. Classical. What is it? That's a very, very interesting. So are these nocturnal panic attacks? Is it laryngospasm? Is it Sandifer syndrome? Or is it a seizure? So that is the differential diagnosis of this condition. And let us see, we did an overnight video EEG and PSG. You can see that very nicely. You know, you can see all these markers here. The EEG is going on, the SpO2 and the respiratory monitor is going on, and all that is going on. And very nicely it is seen. The background is good. Occasional sharp waves are seen. But now during the attack, you see that during the attack, you see suddenly there is a change, and you can see this low voltage fast activity, which is seen diffusely. And at that time, you can see that the breathing is still going on very nicely. You can see that that's the respiratory monitor. So there is no choking of, there's not an obstructive sleep apnea or a central sleep apnea. It is just, you can see that the SpO2 is going on pretty normally there. And the pulse rate is going on pretty well. There's some tachycardia there, but there's nothing else. So this is actually an epileptic seizure. This is classical of an insular epilepsy, where you get this choking sensation. Now, without this polysomnography and video telemetry, I mean, she has had multiple pulmonological consults, ENT consults, but actually it turned out to be an insular epilepsy. Without the video telemetry and the polysomnography simultaneously, it would be impossible to make a diagnosis. And that's a very, very classical this thing. And this is a post-ictal state. See the deep breathing that is going on. Very nice. The very high amplitude breathing, rapid breathing, but there is no drop in saturation. That's the point. So it's not an obstructive sleep apnea. So this is another very interesting phenomenon, rare phenomenon, but interesting because it's a 9-year-old child. And a 9-year-old, when you have multiple daily attacks, 20-25 times of slumping to one side, stiffening of the arms and legs, you get very worried, because this is the age when you have what is called West syndrome setting in, spasms, infantile spasms, and this history of 20-25 times a day stiffening of the limbs and arms for a few seconds from the age of 7 months, only when awake, mostly when dressing up or when dress is removed or when toweling after a bath. But the important point here is that the milestones have not dropped even during these episodes. So usually in an infantile spasm, there would be commensurate reduction of their ongoing background activity, development. So there is no deterioration in cognition, no regression of milestones, but the child is on phenobarbital 20 milligram per day, but no response at all. So we did a video telemetry because we wanted to rule out, is this a tonic seizure? Is it an epileptic spasm? Is it a non-epileptic phenomenon? And she's fallen off and so what is it? This is classical of, and that time during the, you see, this is during the seizure itself, nothing happens in the EEG. There is no, what is called a hypsarrhythmia, normal background, normal child, but repeated attacks like that, not responding to phenobarbital. This is classical of what is called shudder. This is a non-epileptic phenomenon, physiological phenomenon. In some children, you make a diagnosis of shuddering attacks. Nothing need be done. You can stop this phenobarbital, nothing happens. So this is what is called shuddering attacks. Now, are these epileptic? So that was not epileptic. So these are paroxysmal but not epileptic. Now, let us see this boy, 17-year-old, full-term normal delivery, milestones slightly delayed, walked at 1.5, seizures from the age of 3 years, all are stereotyped, always from sleep, wakes up with throaty sounds, gurgling, and right-sided limbs are free, but left-sided limbs are motionless. So that's what he gets. Now, let's see what these are. Now, you'll have to just look at that video, sleeping, and just does that. Oh. So he is nicely sleeping. You just watch him once again. Yeah, he just rubs his nose with that, stretches himself. Nothing more than that. Watch him once more, another episode. And he stretches himself in sleep. Then mean, yeah, he just wipes his face. All. So what would you call this? These are just, it looks like he just stretches himself, wakes up, stretches, rubs his face. This is what we normally do in sleep. I mean, many times we just wake up, I mean, like in sleep, we just stretch ourselves. So these are what are called, generally they are called arousals. They are generally arousals from sleep. And so these are arousals. Now, we thought these are arousals. But you know that we wanted to do a video telemetry for possible pre-surgical evaluation, and exactly that's what we did. And what we found was that I'll again go back to those two videos. But you just see he's got a right-sided focal spiking in the frontal region. Very nicely, you can see that, and very nicely, beautiful slowing of the right frontal region. Very nice focal slowing which is there. And then we have also recorded this track, which is a little more violent. That was the first two you saw, same boy, just arousal. The third one, you know, he is a bit confused now. He looks around, bit lifts like that. And now he comes so that the left hand is bilateral. On the head has gone to the left side, again indicating his right side of focus. So that is what it is. So this is a big one. This is a big one. And now you can see that there is an ictal paresis, not a paresis, but it's actually stiff. So this is the classical of the. So this is the, he had two arousals, and you can see very nicely that this is the first arousal. You see that when we saw that arousal, it's actually not actually an epileptic arousal, because it's actually a seizure. Even that minor attack that we saw, where he just kind of arose from sleep, without this EEG, we would have just told that this is just only a routine kind of an arousal, kind of a mechanism. I mean, just a normal sleep arousal. But this is not a sleep arousal. This is actually an epileptic seizure. This EEG clearly shows a very nice rhythm which is seen on the right side. And again, very nice rhythm which is seen on the right side. You can see that. Now, this is during that arousal here. You can see that, that's it. And that's what it is. So even arousals can have what is called an epileptic arousal. That's a very important point. Now, I'm going to go to the next case. Now, just watch this girl, 18-year-old, first seen in April 2012, forceps, normal cry, milestones normal. At the age of 12, had a GTCS. Since then, once a month, feels a sensory symptom, pulling sensation of the right arm, shoulder to hand, stiffening of the right arm, then right leg, mostly from sleep. Duration 10 minutes to 40 minutes. Now, the daytime attacks are during examinations and is unable to write. So this is what she gets. So she gets a sensory symptom of a pulling sensation in the right arm from shoulder to hand. That's what she gets. And sometimes, many times she gets it from sleep, but she also gets it during stress like examinations, and she's just not able to complete her examination. That's the problem. Multiple anti-seizure medicines have been tried in good doses. Repeated MRI is normal, repeated EEG is normal, diagnosed as functional. Sometimes to unexpected sounds or touch would get the attack. So that is another thing. So we thought whether it's a focal seizure with preserved awareness of left hemispheric origin close to the sensory motor cortex, there may be a startle component because sometimes it is to unexpected touch, or they could be non-epileptic seizures. So these are the three questions we had for which you need to do a video telemetry. That is the indication for this. So we did 24 hours because she gets it. We did not touch the anti-seizure medicine because if you suspect non-epileptic seizure as one of the differential diagnoses, better not to reduce the medicine. So that's a very important point. Now, when we did the video EEG interictally, this is a normal sleep record. This is a normal sleep record, very nice. But many times, just after deep sleep, you can see that there is a run of midline spikes. You see that? Run of midline parietal spikes on the midline and extending a little bit, mainly on the midline. Very nicely, you can see very beautiful midline parietal spikes, run of them. So this, we knew that this is, but this is still interictal. So we do not know what is the ictal. So let us see what the ictal shows. You see this? Epileptic spasms. Repeated spasm. Going into repeat spasm. That is a classical. It's a, when she tried to receive the plate, suddenly it kind of made her start to that, So this is again a stimulus-induced repeated focal spasm involving the right lower limb. Very nice. And now you can see in another position again. Spasm. So that is the classical of that. So what we did was we put an EMG of the leg and the arm, and you can see that each of the spasm is associated with this midline parietal, very nice focal spike and a wave during that time, and that's the time when there is the spasm, because this is the EMG artifact associated during that time, and there is a cortical rhythm here. The cortical activity is this, and the EMG activity is here, clearly proving that this is coming from the cortex and not from the spinal cord or anywhere else. Very nice spasm. You see that this is the spike that is coming from the midline centroparietal region, and 30-40 milliseconds later you can see very nice activity coming from the tibialis anterior, indicating very clearly that this is a cortical phenomenon and not a subcortical. Very nice. You can see that is the, I've expanded the page, and you can see the latency between the cortical activity and the peripheral muscle activity, clearly indicating that this is coming from the cortex. So that is a very interesting phenomenon that you can actually record during a video telemetry. So that's what it is. So what we did was, because this is a cortical reflex spasm, so the best drugs for this would be to give lamotrigine and valproate. And she was very sensitive to valproate, because if you stop valproate, she was getting the jerks. With a combination of lamotrigine, valproate, and a small dose of, and a clobazam, she's completely all right. She did not respond to phenobarbital, phenytoin, and levetiracetam. So again, the video EEG helped us to choose the right combination, and that's what it is. Now you just have a look at this. Is this an epileptic seizure or not? Onset from the age of 2 years, daily or almost daily episodes of seizures of episodes from sleep, both night and day, 2 to 3, wakes up from sleep, restless, sometimes screams, lasts 1 minute, no response to anti-seizure medicines, very hyperactive girl. Now the video EEG was done to characterize the nature of these attacks. Is it a frontal lobe epilepsy? Is it parasomnia? So all we need to do is to do an overnight recording. Whatever anti-seizure medicines were going on, we did not make a reduction. Now I will show you. This would be probably one of the last couple of cases. Let's see what happens in sleep. Very nice recording now. Restlessness, hyperkinetic, screaming. Getting up. What is it? Is it a parasomnia or is it an epileptic seizure? So that is the question. So that is what it is. So you see, gets up, he rolls around, gets up, rolls around. So is it parasomnia or is it an epileptic seizure? That's the question. Now let us see what the EEG showed during that time. And this is the interictal, and during the ictus, there's only a lot of muscle activity. So that's one thing. But through the muscle, you can see in the midline, beautiful beta rhythm that is coming in the midline and on the left side. So this is actually, and then it's dynamic and it's changing in frequency. And so this is a very clearly a nocturnal frontal lobe epilepsy in a small child. And this seems to come from the left hemisphere. It is manifesting as a hyperkinetic, hypermotor seizure. It is not a parasomnia, but this is a nocturnal frontal lobe seizure. So that's what it is. Now, one of the last few cases, you can see this, Mrs. I hope I'm not boring. You can stop me anytime, sir.
So you continue, sir. People
Okay.
are increasing in numbers, sir, as time go by.
Okay. So you see this gentleman and you see how we can go wrong. And all these are practical cases, very important. Everything is clinical. Mr. R, 42-year-old, he had a colloid cyst excision, October 2012. He had a stormy postoperative course, but he fully recovered, no problem. But then, since then, he has been having episodes of shivering the head, stare, both arms tremulous, can fall if not held, frequency 2 to 3 times a month, levetiracetam 3 grams, phenobarbital 120 milligrams, remarkable number of, so he's been treated fully properly in the sense that, see, he's had before the colloid cyst excision, he was normal. Now, he had headache, postural headache, colloid cyst was found, colloid cyst was excised, post-operative course was a bit difficult, but he improved and became normal. But after that, he started having post-operative seizures. And that's what was going on. And to increasing doses of medication, he was not responding well, but he's actually been followed up by the neurosurgeon himself for a long time. And no neurologist has actually seen him. So that is one of the things. And the problem was in the last 2 months, it became daily 4 to 5 times, sometimes from sleep. Levetiracetam 3 grams, clobazam was added, 30 milligrams. The problem was then after this regime, he became markedly bradykinetic, dull, apathetic, postural instability. And he was actually referred for video telemetry because his attacks are coming regularly now. And so that's what it is. So he's been treated appropriately, adequately, massively, but he was still continuing to get, it was actually increasing in frequency. So what are these episodes? Episodes, are they epileptic? Are they non-epileptic? Video EEG we did for 24 hours because he was getting 4 to 5 per day. So you don't need a longer one. So whenever you suspect a non-epileptic, I told you that it's better not to stop the anti-seizure medicine. So I will tell you why later on, but that's the... Now let us see what he does. Nothing there. His wife recognizes that, he's under attack. He was attacked. I'm there. He himself said, he's just like that other girl. You saw that girl that time. First thesis. And I'm trying to ask things.
What's your name?
Not responding. He's This is called the testing. Testing. You have to keep on repeatedly asking the same. And again, now you shake. Repeatedly helping. Not responding.
பேர் சொல்லுங்க. பேர் என்ன? பேர் என்னங்க? கண்ணு சொல்லுங்க. இங்க பாருங்க.
Simultaneously the EEG is going on.
இங்க பாருங்க. இங்க பாருங்க.
You can always review the EEG during this process.
நாக்கு நீட்டுங்க.
So he is completely unaware.
கண்ணை மூடுங்க. கண்ணை திறங்க.
So that's what it is. So I'm going to show you the next. You see that during that episode where he suddenly started doing that shaking of the limbs, just like the other girl, that other girl whom we showed, which showed that generalized activity. Here we were surprised to find that there's a very nice rhythm that is going on. This is a lot of artifact because of the, you see that this is a masseter which is contracting, that. So that's a rhythmic masseter contraction, which is resulting in a very rhythmic activity. So he's repeatedly, contracting his masseters, and that is like almost like and then when you cut off the filter, high frequency filter, so that you cut off the muscle activity, you can see this very rhythmic, high amplitude, same rhythm, monomorphic rhythm, which is occurring throughout like that without any ictal transformation. In other words, there is no dynamicity. It's the same activity. And so we knew that although it looks like an ictal rhythm, this is too monomorphic without any dynamicity. So it's unlikely to come from the brain. That is our inference looking at the EEG. Although the EEG looks as if there is an ictal transformation, but it is too monomorphic for a seizure. The seizure never remains in the same frequency for 10 seconds like that. It is impossible. Now, what we did was, I said, okay, maybe you're going to get a seizure now. And what I did was, I will now place
sometimes கொஞ்சம் ஜாஸ்தியா வந்தாலும் கையா shaking.
Immediately performs. Gets the same phenomenon. Starts shaking his head like that. So he got the same episode that he got in same way, just by giving a suggestion, a simple suggestion that you're likely to get an attack by putting a vibrating tuning fork over the forehead, and he immediately got it. And that had the same characteristic on the EEG. You see, so the induced attack also had the same electrical signature as the spontaneous attack. And this also did not evolve. It's the same frequency, clearly showing that all the attacks are not coming from the brain. It is coming from his mind. So these are psychogenic, non-epileptic seizures. So all the years of 3 years after his colloid cyst excision, what he was getting were non-epileptic seizures, and he was on massive doses of anti-seizure medicine, when actually he never had seizures. So that is the importance of doing a video telemetry in these kind of episodic paroxysmal phenomenon, which is not responding to medication. Better to actually do a test and see whether this is actually the. So after video EEG, what we did, gradual withdrawal of levetiracetam and phenobarbital, Clobus, and only on escitalopram, all extrapyramidal signs disappeared. He's back to work, completely normal. So we actually, so it was actually more of an iatrogenic phenomenon because of our lack of understanding of what is the phenomenon that we are treating. That is the point that I'm trying to make. And so a simple test like video telemetry, you know, it would have cost him about some 10,000-15,000 rupees, but then it has changed his life. And so that is the important point. So it is very cost effective if you do it in the right way. The last category, and I'm going to stop with that, is the pre-surgical evaluation. You see this girl, 22-year-old. It's a very interesting case. Just observe this girl, 22-year-old, full-term cesarean section, 2.5 kilos, milestones normal, no history of febrile seizure, no trauma, no meningoencephalitis. She's been having seizures from the age of 14 years. That means for the last 8 years. And then you see she's got two types of seizures. The type 1 is that she gets an aura of a occipital or bitemporal headache. Now this is followed by prominent chewing movements and leg movements and upper limb posturing. She is unaware, and occasionally it goes on to generalized tonic-clonic seizures. So that is the type 1. So aura of headache, bitemporal, prominent chewing movements, and upper limb posturing. The type 2 is very, again, the same aura is the same. Headache, occipital, bitemporal. Then she falls down. Once she falls down, she lies still, there's no movement. So the first one, she has a lot of movements, in the sense perioral movements and some kind of automatisms. But here she lies down still, no movements, no response to calling, no sphincteric incontinence. Now the frequency is the same for both types. Each one she gets about 4 to 5 per month. So cumulatively she gets about 10 attacks a month. So that's the thing. The type 2, she gets in wakefulness. The type 1, she gets both in wakefulness and in sleep. The type 1 can cluster. Cluster means sometimes 2 or 3 on the same day, but in type 1 is usually 1 attack. So that's what it is. So this is what it is. So with this, you see her current medicine, she's been treated appropriately, because this, if it is a seizure, it is a focal epilepsy without a doubt, with impaired awareness. And so therefore the choice of carbamazepine is correct. The choice of clobazam is correct. The doses are correct. And she's been tried on various different anti-seizure medicine in appropriate doses. Nothing has worked. She continues to get the same phenomenon. And she's very depressed. She has temper tantrums. The classical of any uncontrolled epilepsy. You know, this is how they normally are. So there's nothing drug-resistant CPS is now no longer called CPS, is focal epilepsy with impaired awareness. We don't know whether it's coming from the temporal or extratemporal. Are there 2 seizure types in truly? So these are the questions that are asked. And we did the video EEG prolonged one. You see very nice temporal intermittent rhythmic delta activity, TIRDA, on the right side, F8T2, right anterior temporal. No doubt that this is the focal epilepsy is coming from the temporal lobe and coming from the right temporal lobe. That there's no doubt about it. So that's TIRDA. And on an MRI, we found that there's a very nice dysplasia which is seen in the right parahippocampal gyrus. There's no doubt about it, very nicely seen. And the PET also shows a very nice focal hypometabolism in the same region. So there is no doubt, oh, this is a right temporal lobe epilepsy. There's a lesion there. Lesion is a dysplasia. And everything is matching. You know, interictal is matching, structurally is matching, functionally it is matching. So, but we need to still record our attacks. That is a very important. And importantly, whatever the patient tells you, you have to record all the types. Say she has told us about 2 types. We have to record both the types. So now we did in January 2011 for 72 hours. Now we recorded. Okay, I will just a minute. You give me this is the last case, sir. So I will. Problem. Interesting case. So that's. Is it seen?
Not coming.
Is it seen now, sir?
Yeah, same.
No.
Audio is seen. Click on that.
Huh?
Just
Is it
click
seen,
on.
sir?
It's seen, sir. Yes, sir.
Wait, I'll do that. I'll do that. Right, it will come now, sir.
Oh, yeah.
It will come now. Yeah. Yeah, just see now. And you have to decide what type it is. You know, she's complaining of the headache. See, she's pointing out to the head. And then she goes like that, she drops off. Hypomotor, motionless. She just falls down. Absolutely no response. Mother has watched it. Just like that other gentleman, I was testing, now the nurse is testing. Just like that other gentleman, she is also not responding. Absolutely no response. She's lying down like that, flat. Absolutely no response. Absolutely no response. The mother is rubbing her, the sole of. Absolutely no response. So she's just lying like a statue, log of wood, nothing more than that. So, and when we recorded the EEG during that, you can see that she's fallen off like that. Background is normal. Classical. You see that the EEG is not a single change in the EEG. Very nice background rhythm going on, alpha rhythm, because she's kept her eyes closed. So she's got a nice alpha rhythm that is going on. So this is her type 2 seizure was recorded. Type 2, and this seems to be clearly a non-epileptic seizure. Parents confirmed that this is one of the types. But they also told that there's another type, but unfortunately the type 1 seizure was not recorded during those 3 days. She had only this type 2 seizure. So the parents and patient were counseled regarding the 2 types. And what we did was we said that, this type 2 is not coming from the brain. It is not coming from that area where the brain MR abnormality was seen. It is coming from somewhere. It's coming from deep inside the mind. So we counseled and we strengthened the patient. We gave her counseling and said that, you'll have to slowly get out of that. Then we can help you to get the type 1 seizure out of your way. So over the next 10 months, the type 2 seizure, which is a non-epileptic seizure, completely stopped. And then we brought her back. See, this was January 2011. We brought her back in November 2011 when the parents said that, no, nowadays she doesn't get that type 2 seizure which we had recorded. Now we did again another video telemetry. So let us see what that one shows. So let us see what that one shows. Yeah. That's it. Yeah. Face. That's perioral automatism. Otherwise, still not noticed that. He was trying to attract the attention of the mother from doing automatisms. Mother doesn't know that it's his Mother still doesn't know. How there's some state movement. Oh, suddenly the mother was realized, oh, that's how to resist the button. get up. Earlier she was not trying to get up. And so this is classical of, this is a typically a partial seizure of temporal type, hypomotor with predominantly lip smacking, oroelementary automatisms. And you can see that the pre-ictal, and you can see that the very nice rhythm coming from the right temporal lobe. So now we have proved that there is a interictal discharges from the right, MRI showing right, PET showing right, the ictal also showing right. So now we know that, and then we have stopped the type 2 non-epileptic seizure. And so then that's a very nice prominent chewing automatisms, very nice EEG. You can see that. And through that, you can see that very nice rhythm, which is seen only on the right temporal region, nowhere else. And this is the post-ictal slowing, which is quite diffuse. So March 7, she underwent a surgery, and that's it. And she is now normal. So the point is that how the video telemetry has helped us in recognizing both epileptic and non-epileptic seizures in the same patient. You treat the non-epileptic seizure, then you treat the epileptic seizure, all because of video telemetry. So the video telemetry is an extremely important, useful tool in the evaluation of paroxysmal episodic neurological phenomena. That's the most important thing. Can effectively change the management course of a patient. I have shown you a lot of examples of them. Is cost effective if used judiciously. That's the most important. Combination of true and non-epileptic seizures is quite common, and I showed you a nice example of that just now. Important to get clues from the history, and then you confirm it by video EEG. Video EEG is crucial in pre-surgical evaluation, even in straightforward lesional cases. I just gave you an example of that. So thank you very much for your very patient listening, and apologies for some glitches at times. But I think I thoroughly enjoyed giving this lecture, but I don't know how much our audience would have liked it. But thank you.
Thank you. Thank you very much, sir. Everyone enjoyed, sir. Thank you. It was very nice, sir. Nobody wanted to go. There is a time constraint only, make them go. Thank you. Thank you very much, sir. We'll continue with your good work for us, sir. Thank you very much, sir.
Thank you very, very much, sir, for it was very enjoyable, and I hope this has ignited some interest in this field. Thank you.
Definitely, sir. Definitely, sir. More people will take up. Thank you, sir. Yeah. Thank you very much, sir. Thank you, everybody. I have got the recording. Someone needs it, you can just contact me sometime later. Thank you, sir. Thank you very much. Thank you all.
Thank you, one and all. Thank you. Bye.